We're going to talk about the section 1, and I already told you that in section 1 we're going to talk about anatomy and physiology of the breast tissue. Then we're going to talk about the medical history, what are the symptoms the patient can report to you, or what are actually the specific key points in the history you're actually looking in the patient. Then we're going to talk about examination, and then we're going to talk about particular specific investigation in a patient who is presenting to you with a breast lump or nipple discharge or even mastalgia. So here we go. This is the anatomy of the breast tissue. You can appreciate the diagram, and in the diagram you can see that there is basically the whole of the breast tissue is actually covered with the skin, and underlying the skin there is a subcutaneous tissue. And you can also appreciate this is basically this whole of it's a breast mass, and then you can also the actually parenchyma of the breast, and then you can also appreciate the nipple, and surrounding area around the nipple is called as areola. In the other cross-sectional picture, you can appreciate this is basically the whole of the breast tissue is composed of fatty tissues. You can appreciate in the diagram, and you can also see different lobes, and these lobes are actually they are entering into the ducts, and the ducts are then actually entering into the nipple and areola. You can appreciate that this is basically the area which is surrounding the nipple. So if we talk about the boundaries of the breast tissue, so you can say that superiorly and inferiorly, actually the breast tissue is surrounded by the ribs. So superiorly you have the second rib, and inferiorly you have the sixth rib. So you can say that the breast tissue is actually extending from superiorly from the second rib to the sixth rib inferiorly, and medially you can medially the boundary is formed by the sternal edge, and laterally the boundary is actually formed by the mid-axillary line, or you can also, if we go more laterally, you can also include the axilla basically, and the contents of the axilla into the lateral boundary of the breast tissue. And if you talk about the posterior boundary of the breast tissue, there is deep investing fascia of pectoralis major muscle, you have serratus anterior muscle, you have external abdominal oblique muscles, and you also have upper extent of rectus sheath. So telling you once again about the boundaries, superiorly we have second rib, inferiorly we have sixth rib, medially there's a sternal edge, laterally you have mid-axillary line, and there's also axilla with all the contents of the axilla. They also come more lateral to the breast tissue. And then if you talk about the posterior boundary of the breast tissue, you have deep investing layer of the pectoralis major fascia, and you have the serratus anterior muscle, you have external abdominal oblique muscles, and then you have the upper extent of the rectus sheath. So we're going to talk about the structure, and basically in the previous picture I also showed you that basically the breast tissue is covered by the skin, and underlying the skin you have the subcutaneous tissue, and underlying the subcutaneous tissue we have the breast parenchyma. So if we talk about the skin, let me tell you that the skin of the breast tissue is very thin, and it contains the hair follicles. And if we talk about basically what the breast tissue is it's actually a modified sebaceous glands. So that's why in its structure you have basically the sebaceous glands which are opening into the nipple of the breast, and you have the exocrine sweat glands as well. So this is basically the composition of the skin. If we talk about the subcutaneous tissue, you have fat, vasculature which is supplying the skin, the lymphatics, and the nerves. Now I already told you that actually the most of the mass of the breast tissue is composed of the fat. So the weight of the breast tissue is also depending upon the percentage of the fat which is found in the women. Like if a woman is obese, or if a woman is fatty and she has more distribution of a fat in her body, then obviously the weight of the breast tissue will be more in her as compared to the woman who is lean and have less fatty tissue inside her body. So this was about the subcutaneous tissue. And if we talk about the breast parenchyma, you have the parenchymal components, you have the stromal components, and you have the lobules. So already shown you in the previous slide that basically there were lobules, and the lobules were entering into the ducts, and actually lobules are basically actually secreting the milk, and the milk is delivering to the nipple through the ducts and smaller ductules. So actually there are 15 to 20 ducts and 15 to 20 lobules which are present into the breast tissue. So this was all about the anatomy of the breast tissue. We're going to talk about the blood supply. So you can appreciate in the diagram that there's external mammary artery, and there are a lot of branches which are coming from these mammary arteries. You can also see second internal mammary perforators, because actually the main artery is external mammary artery, but you have the perforators which are coming from these external mammary artery, like anterolateral intercostal perforators, second internal mammary perforator, and also branches from the lateral thoracic artery. And obviously you can also appreciate the internal mammary perforator and anteromedial intercostal perforator. So all these branches are actually either the branches of lateral thoracic artery, or they're the branches of the external mammary artery which are coming and supplying the breast tissue. So this was about the blood supply, and now we'll discuss about the lymphatic drainage of the breast. Surgically, let me tell you guys that this is very, very important, because whenever the patient is coming to you with a breast lump, or even whenever the patient is presenting to you with a nipple discharge and you're suspecting a carcinoma, then you have also you need to examine the axilla, which is very, very important, because almost 75% of the drainage of the breast tissue, that is in the axilla, and specifically the apicular group. So this is very important to examine the axillary tail. And this was actually important in the clinical aspect, but if when you're performing the surgery in a patient, like mastectomy or radical mastectomy or modified radical mastectomy, so you have to look for the axillary tail you have to perform actually axillary tail dissection to look for the different kinds of the nodes, if they're being invaded by the metastatic cells, or if they're being they're embedded, or the cancer is actually metastasizing into the axilla. So you need to look for these lymph nodes. So that's why lymphatic drainage of the breast tissue is very important. Actually, we divide the breast tissue into 4 quadrants: outer quadrant, inner quadrant, lateral quadrant, and medial quadrant. You can say outer upper quadrant, you can say inner lower quadrant, you can say medial quadrant, and you can also say the lateral quadrant. So actually, if we talk about the lymphatic drainage of the breast tissue, we divide it into lateral quadrant and the medial quadrant. You can see in this diagram that all of the medial, this is the medial, actually this is the demarcation line, and you can see that this is actually the medial quadrant, and this is the lateral quadrant. So the medial quadrant is draining into the internal mammary nodes. You can see into this diagram that basically this is the medial quadrant, and these are the breast tissue, these are the lymph nodes alongside of the medial side of the breast tissue, or they're draining actually the medial side of the breast. So these are called as internal mammary nodes, or they're called as internal thoracic nodes. So the medial quadrant is draining into the internal mammary or internal thoracic node, and this is the lateral quadrant of the breast. You can see here, lateral quadrant of the breast is draining into these scapular group. They're draining into the subclavicular apical group, which are actually lying in the axillary tail. You know that the axilla has 6 groups of the lymph nodes which are actually lying in the axilla, but most of them, the important group is the apical group, or the subclavicular group, into which the lateral quadrant of the breast is draining. So always remember that medial quadrant of the breast is draining into the internal mammary or internal thoracic, and the lateral quadrant of the breast is draining into the subclavicular or the apical group. And whenever you're suspecting, I'm again repeating, this is very, very important, if you're suspecting a carcinoma, or if a patient is presenting to you with a erosive mass, you have to look for the axilla, you have to look for the lymph nodes if there is metastatic disease which is extending into the lymph nodes. So that's why clinically and surgically lymphatic drainage of the breast tissue is very, very important, and you need to memorize it very keenly. So now coming to that was a little bit about the anatomy, blood supply, and the lymphatic drainage of the breast tissue. Now we're going to talk about, if the patient is coming to you, what you're going to ask the patient in general and specifically in premenopausal women and the postmenopausal women. A patient may present to you with the mastalgia. Mastalgia is basically the typical breast pain, and the patient may present to you with the breast mass, or the patient may present to you with the nipple discharge. So what you gonna ask the patient regarding her condition? In general, you have to ask about the age of menarche, like what was her age when she menstruated for the first time, and you have to ask if the patient is married. You have to ask for the number of pregnancies and live births. You need to ask if she was actually breastfeeding her child or not. You need to ask for the age of the patient when she gave birth to her first child. You need to ask for the family history. You need to ask for the breast biopsy. So in general, what you're going to ask is, you're going to ask about the age of menarche. You need to ask about number of pregnancies, live births. You need to ask about age at the first birth, family history, and you need to ask about any kind of breast biopsy she underwent before coming to you. And then what specific thing you're going to ask in the premenopausal woman, that is date of the last menstrual period. You'll ask about the length and regularity of the cycles, and you will ask about oral contraceptives. Why? Because this is a very, very important. All of the oral contraceptives, pharmacologically, they contain a lot of hormones in them, and so that's why they can actually stimulate the breast tissue, and that can convert into proliferative or non-proliferative breast disease. So what we're going to ask in the postmenopausal woman, that is date of the menopause, and you have to ask for the hormone replacement therapy, because most of the patient, when they actually they're in their menopause, they are actually experiencing a lot of menopausal symptoms. So for that, the doctor gave them a hormone replacement therapy, like to combat different kind of symptoms like dizziness, body aches, backache, so you need to put them on a hormone replacement therapy. So these are the important things you need to ask in the history. If the patient is coming to you with the breast complaint, in general, you need to ask for the age of menarche, you need to ask for breast biopsies, number of pregnancies, live births, age of the patient when she gave birth to the first child. You need to ask for the family history, if there is a family history of any breast diseases, if there is a history of ovarian cancers, because they're very much closely related to each other. And then you're going to ask about, in the premenopausal woman, you need to ask about the date of last menstrual period, length and regularity of the cycles, use of oral contraceptives. And in postmenopausal woman, you need to ask for the date of menopause and use of hormone replacement therapy. So this was all about the history, but in specifically, what are you going to ask? You need to ask for the onset, if she's complaining of mastalgia, or she's complaining of the breast pain. You need to ask the onset, for how many days, it was gradual, it was sudden in onset, it was gradual in onset, for how many days you have been experiencing these symptoms. You need to ask for the duration, the pain is progressive in nature or it is non-progressive. You feel the pain whole of the day, or the pain comes in episodes. You need to ask for the frequency, and you need to ask for the severity of the pain as well. And then you need to ask for the relationship to the menstrual cycle, or the use of the hormone replacement therapy. If she's complaining about the pain, then you need to ask like if she's feeling more pain during her menstrual cycle, or there is no relationship with the menstrual cycle. So these are the things which are specifically you need to ask to your patient. So that was all about the history. We're going to come to the clinical examination. After history, the most important thing is the clinical examination. So in breast examination, inspection and palpation, these are two important steps. You are actually, they will help you in making the diagnosis in your patient. Like in inspection, what you're gonna look for, you look for symmetry of the patient, actually symmetry of both breasts. You need to look for the nipple shape, like it is shape, texture, if there is any kind of the discharge which is coming out from the nipple, or you need to see the ulceration in the breast tissue. You need to see the symmetry of both breasts, like size of the both breasts equally or not. So that was about the inspection, and then the next step is the palpation. And in palpation, I'll tell you in detail how you're going to palpate the patient who is coming to you with a breast lump or the breast mass. So first and the most important thing is that you need to examine the patient in supine and upright position, right? So in supine and upright position, what you're going to look for, I already told you, you look for asymmetry, you look for deformity, you look for skin changes, and if there, and then you have to move to the next step, that is the palpation. So if a mass is found, you need to look for the size of the mass, you need to find out the shape of the mass, you need to look for the texture, tenderness, fixation, location. Now, what do you mean by fixation? Fixation, like if you are palpating the breast lump and you feel like it is fixed to, or it is tethered to the skin. So this is basically the fixity of the mass you're looking for. In location, like it is in the upper outer quadrant, it is in the outer lateral quadrant, it is in the medial quadrant, or it is the inferior quadrant, or inner quadrant of the patient. So these are important things. You're looking for a patient who's coming to you with a mass. And if there's a nipple discharge, what you're going to look for, you look for color, you look for quality, whether it is associated with a single duct or associated with a mass. It's like there is a singular duct which is actually presenting to you with a discharge, or it is associated with some kind of a mass you're actually filling. Then at the end, I told you that you have to look for the axillary trail. Why? Because the lymphatic drainage is going into the axillary trail. You look for the lymphadenopathy. If there is a lymphadenopathy, and you confirm it through mammography or ultrasound or other investigations, then you have to undergo the patient axillary tail dissection for the metastatic breast disease. So in axillary tail, you have to look for the axillary, supraclavicular, infraclavicular lymph nodes. To summarize this clinical examination, you have to do the inspection, you have to do the palpation of the patient. So these are basically the position. The figure A is actually the upright position, figure B is the upright position, and the figure C is actually the supine position. So in upright position, what you're going to look for, you ask the patient to sit in an upright position. You need to inspect, you need to look for symmetry, you need to look for actually the shape of both breasts, you need to look for the shape of the nipple, and then you will proceed to palpation. And you have to actually palpate the breast in quadrants. I told you this is the upper outer quadrant, this is the lower quadrant, this is the medial quadrant, and this is the lateral quadrant. So here you go, you palpate the patient in first 4 quadrants, and then you ask the patient to actually fold her arms just behind the head, or place the head place her hands under her head and take a supine position, and then you have to palpate the breast tissue in a clockwise position initially, and then into the anti-clockwise position. So these are important positions you have to make. Okay, so this was about the clinical examination. Now coming to the breast imaging. What you are actually ordering in the patient to look up for the mass, or to make a probable or the definitive diagnosis. There are actually 4 modalities, like one is mammography, other is ultrasonography, then you have the magnetic resonance imaging, and then you have the biopsy. Now, what is the factor which is deciding if you're ordering for the mammography or you are ordering for the ultrasonography? That is the age of the patient. If the patient is less than 30 years, then you have to order the ultrasound. And if the patient is greater than 30 years, then you have to. Some books are saying 30, and some are saying like 40. So it depends upon the age of fertility of the patient. So we can say that if the woman is in her fertile age, you have to order for the ultrasonography. And if the patient is out of her fertility age, like menopause, you have to order for the mammography. And then you have the magnetic resonance imaging, and then you have the biopsy, and the biopsies that depends upon actually the like it's a core FNAC for fine needle aspiration cytology, or you'll go for biopsy like it's a true cut biopsy, it's a needle biopsy, punch biopsy, or sometimes it's excisional biopsy. So regarding mammography, what you're going to look into this on my right, you can appreciate that there are different pictures with the mammograph, and you have seen here this is the white calcification, because actually you can see that this is a fibroadenoma. So actually what happens that if a mass, if there's a solid mass, and specifically if we talk about the fibroadenoma, there would be calcification. And in mammography, you will look that there is basically the calcified mass. You will found out to have a calcified mass in the mammography. So this was about the breast imaging. You'll order for mammography, ultrasonography, depending on the age of the patient or the fatality of the patient. Then you have to order for the magnetic resonance imaging, and then you have to order for FNAC fine needle aspiration cytology or biopsy. And the biopsy is like it depends upon it's a needle biopsy, or it's a true cut biopsy, punch biopsy, or it is actually excisional biopsy. So there's another thing which is very, very important for you guys to know what it is. That is triple assessment. It's very important surgically, clinically. You need to know what is a triple assessment. What does that? It means actually if a patient is coming to you with a breast lump or the breast mass, you have to evaluate that patient on the guidelines of the triple assessment. So what is actually triple assessment? It includes three things: clinical, imaging, and the pathology, right? So in clinical, what are you doing in the clinical aspect? Actually, you're asking for the patient for a detailed medical history, and then you have to undergo the patient through a detailed medical examination, right? So in clinical, there are two things which are very important: a medical history and then detailed medical examination. In imaging, this is ultrasonography or mammography. And again, it depends on the age of the patient. If less than 30, it is ultrasonography. It is greater than 30, it is mammography. And after ultrasound or mammography, you're making a confident diagnosis. And if at all you're unable to make a confident diagnosis with ultrasonography or mammography, you have to perform, you have to actually do the pathology. And in pathology, what you're ordering is a fine needle aspiration cytology or needle biopsy, like it can be a punch biopsy, true cut biopsy, excisional biopsy. So this all includes a triple assessment. So what is actually important in the triple assessment? Clinical, imaging, and pathology. Clinical, medical examination, history, imaging, ultrasonography, mammography, and you make a confident diagnosis. And then in the pathology, this is fine needle aspiration cytology. Okay, so this is a very, very important flow sheet. You need to memorize it. You need to learn it by heart because it's really, really helpful. It's really going to help you in making a diagnosis or to manage a patient who's coming to you with the complaints of a breast mass. What you will do is actually you'll perform the history and you will actually perform the clinical breast examination, right? And when you have done this thing, you have performed the history, you are done with the clinical breast examination, what you're going to do is you're actually looking for the findings. If you have performed a clinical examination and your examination suggests no mass, what you are going to do is repeat clinical examination in 2 to 3 months. If you have performed a clinical examination and you have found out to have a probable benign mass, or there is actually asymmetry in both the breast tissues of the patient, what you're going to do is you have to order for the ultrasonography, or you have to order for the mammography. It's less than 30 years is ultrasonography. If the age is greater than 30 years or more, it is actually mammography with or without ultrasonography, right? And there is another thing which is very, very important. This is bi-rate classification. Now, there's a question, what is actually the bi-rate classification? This is actually to differentiate between benign and the malignant diseases, and then you have to follow the bi-rate for actually the prognosis of the patient. Like if it's bi-rate 1, that means it's negative, and you have to re-examine the patient, or if there's some clinical indication, then you have to consider the biopsy. And if the scale is bi-rate 2, that means benign, routine follow-up, it's consistent with examination. And then there is a bi-rate 3, that means probably benign, and repeat imaging in 6 months. And or either way, you can also, if clinically indicated, you can also perform the biopsy as well. And if it is bi-rate 4 or 5, that means it is suspected malignancy, and you have to order for the biopsy, and image guiding needle biopsy is preferred. And there's another thing, if you are doing a clinical examination and you have found out a suspected mass. Now, how would you say that the mass is suspected to be malignant? If there is ulcerating lesion, and if the ulcer is bleeding, or there is asymmetry of the breast, or there is nipple discharge, and maybe it can be a serous discharge, or it can be a bloody discharge. But mostly, if it is a malignancy, then the discharge is serous and bloody discharge, right? And also, if there is a retraction of the nipple, or there is the skin tethering, then you can say that this is a suspected malignant mass. What you're going to do then, you're ordering a mammography, or you're ordering an ultrasonography, and then you're also proceeding for the biopsy ahead. So to memorize this, you need to memorize this very, very keenly, because this is a very important slide. And if a patient is coming to you with a breast mass, perform history or clinical breast examination. And if there is no suggestion of a mass, what you're going to do is repeat the clinical examination in 2 or 3 months. And if there is a probable benign mass, or there's asymmetry of the breast, if the age of the patient is in fertility, like age is less than 30 years, then you have to perform the ultrasonography. And if the age is greater than 30 years or more, you have to order for the mammography, or it can be with ultrasonography, or it can be without ultrasonography. And then you have the bi-rate 1, 2, 3, 4, or 5. Bi-rate 1 negative, that means repeat the clinical examination, or if the patient is clinically suspected, you can order for the biopsy, or other investigations. If the bi-rate 2, that means benign, and you have to follow up the patient. And if it is bi-rate 3, that means it's probably benign, and then repeat the imaging in 6 months, and biopsy if clinically indicated. And bi-rate 4, that is suspected malignancy, you have to order for the biopsy. But if you are clinically suspecting a malignant mass, what you're going to do is you're going to order for the mammography, you're going to order for the ultrasonography, and you're proceeding for the biopsy. So you need to memorize this. This is very, very important flow sheet. So far in this section, we have discussed 3 things which are very important. We talk about the anatomy, we talk about the blood supply, and we've talked about the lymphatic drainage, which is clinically and surgically, it is very, very important, because there's metastatic invasion that's going to involve the lymph nodes, and you have to perform axillary tail dissection if you're performing a surgery. So this is very important to know the lymphatic drainage of the breast. Then we have talked about, like, if a patient is coming to you, what specifically you're going to ask in the history. You need to ask for the age of menarche, age of menopause. You need to ask for the regularity or the length of the cycle. You need to ask for oral contraceptives or use of any hormone replacement therapy. And you need to ask for the number of the childbirths, pregnancies, live births, and also what was the age of the patient when she first gave birth to the child, right? And then you need to perform a clinical examination. And the most important step in the clinical examination are basically clinically, inspection and the palpation, right? So inspection, you need to look for the symmetry of both the breasts. You need to look for the nipple discharge, nipple shape, retraction, like all these things. And when you're performing a palpation, you have to palpate in the upright position, you need to palpate in the supine position, and then you look for any mass, size, symmetry, skin fixation, location. These are very, very important things you need actually to perform during the examination of a patient who's coming to you with a breast disease. Now we also talk about the imaging modalities like mammography, ultrasonography, magnetic resonance imaging, and the biopsy. So this was all about the section 1, and I would be coming up with the section 2 and section 3, and we would be talking about palpable masses, and we talk about the proliferative and non-proliferative diseases. So thank you for watching sqadia.com. For the detailed version of section 2 and section 3, keep watching Sqadia.